and the day is right. She's a haunted.
First and foremost, I would like to say thank you to all the participants, the speakers, of course, and precisely now in times when either one is already on holiday or at least one is thinking about the beach or the mountains. So thank you especially to the Spanish Association for this activity, and most especially to Jordi for his enthusiasm, his eagerness, his endless energy, and also because he's the driving engine, really, of everything. This is an activity that I'm very happy to participate in as a physician, because I think that it gives me the chance to learn about a very important disease, the Gaucher's disease, which is a disease that, first and foremost, well, as I was saying, is going to, well, it's sometimes difficult for us as physicians, and it has to be patients who open the way, because what's most important is the patient. Sometimes we professionals get lost in molecules and therapies, but what we want as physicians is to treat patients and for patients to be well in their daily activities. And this is indeed what I'm going to try to illustrate in some introductory words. I have a few slides to share with you. And, well, if technology allows, well, I'll go ahead. First of all, let me tell you, I'll be the chairperson. I'm Vicente Giner. I work in internal medicine. I have some experience in Gaucher's disease. I work in Alicante in the San Juan Hospital, and right now also in Alcoy, where we have a number of Gaucher patients. Well, in 4 or 5 minutes, I'm going to be giving you my standpoint, because I think that this activity here, in which we are remotely, I mean, the idea is to get, a feel about Gaucher's disease, and it's good to contextualize the standpoint of a physician, of a clinician regarding Gaucher's disease. And I would class this, of course, in therapeutical improvements, because Gaucher's disease, up to not all that long, was untreatable. 20 years ago, we tended to focus on organs, on preventing the death of the patient, pain from happening. But these last 20 years have meant an eclosion, an explosion of things happening that makes it possible for us now to have healthcare focused on people and not so much on the organs, on the spleen or the liver, but rather on the person, without forgetting, well, obviously the spleen and bones too. This has been seen in therapeutical guides. The first ones that came were rather heavy going, because it tended to focus on hemoglobin, on volume. But the most recent guides, as to, well, the review, I was delighted to read them, because we see that patients had been included already, and these guides, the guidelines tended to focus more on patients and their lives, on pain as well. Although personally, I expected somewhat more visibility of the patients themselves. And then what about evolutionary goals? At the beginning of the disease, our resignation was for the patient to continue to evolve in an unstoppable way with pain and complications. Later on, we realized that we were able to stabilize and even normalize that pathology when we started the treatment timely. So I think that now, and this I do absolutely believe, well, it's the very core, the raison d'etre of our meeting now today, is we have to focus on the person, not on the patient. Or we have to focus on quality of life, and we can do it because now we have treatments that make it possible for us to even adjust the therapy for each patient. I love this sentence. Yes, it's tailor-made medicine, and this is a name of medicine, and it's happening. But especially in lysosomal diseases like Gaucher, one has to think first and foremost about the person, not about the patient. We have to think about the function, not the organ. Here you see the 2018 guidelines. I'm so happy. One can tell the change. Yeah, I mean, before we talked, for example, in bone, we didn't want necrosis, but now the idea is for the kid to develop and for the adult to be able to walk properly without pain. There are, however, the way I see it, a number of things that have to be organized in Gaucher's, and some things have to be improved, definitely. And this is the reason why we're here today, to listen to the patients especially. I'm really eager to listen to them, because that way I will readdress. Yes, this is a very personal standpoint I'm giving you about what nowadays, with new technologies, could be the organization of Gaucher's patients' healthcare in Spain. In the center of everything, over and above everything else, in the black circle, we have the the patient and surrounding patients without patients having to travel long distances or doing special things. We have primary informed, documented primary care, also pharmacy that tends to be forgotten, and also a structuring between the closest healthcare center and the famous seizures, which should evolve and prevent these displacements and travelings of the patients through technology, sharing tests, and using technology as we have it available now. So this would be an organizational proposal. I think that nowadays it's not really ethical at all to make a patient travel 200 or 300 kilometers or even 100 kilometers to be given, in the case of Gaucher's, adequate healthcare. But there's also something else that I like to talk about, which is the home medication. And people are scared about it, and there's no evolution there, unfortunately. Here you see a graph of a national program of enzyme therapy infusion for Hunter, Rocher, and Gaucher patients. Obviously, with COVID, things, well, have forced technology, really. And there are clear advantages for home treatments here. And there are a number of different patient associations wanting good quality of life. So the impact, however, has been rather nil in some groups. We'll talk about it, about why this happens or doesn't happen, this home care. And anyway, I want to focus then on the patient, yes, on the people too, but people who have the disease and what the disease entails. For all this, we have this program this afternoon. We have, well, excellent speakers with huge experience, especially personal experience. First of all, Dr. Ari Zimran, a world authority, possibly. He's the physician who is in charge of more patients with Gauchers in Israel. Professor Zimran had problems that made it impossible for him to participate physically, but he did, however, record his presentation. And, well, remember, through MPS, the association, any question you might have, you can put through. Then we'll be listening to, well, he's going to talk about doing away with borders and therapy. But then we're going to be hearing patients. We have Chandra McLean with us from Canada. She's going to be talking about her personal experience with therapy. And then for another standpoint, we also have another Gaucher patient, Alejandra Tornero from Argentina. And then our idea would be to have a Q&A session, but more than a Q&A session, rather a discussion, yes, an opinion exchange, and, well, impressions and comments, not only questions and answers. So with no further ado, I shall go on now to give the floor to Professor Zimran. As I said, we have the possibility for the people in the audience to send remarks, questions, and we will work on them all in the Q&A discussion session at the end of this session after the presentation. So I hope you enjoy this. And I guess we'll all enjoy this meeting. And it's good that we can be talking and attending from different places, even the beach and the mountain. But it's good so that we learn. I'm sure I'm going to be learning plenty. And sorry for being egocentric. I know I'll learn a lot.
Okay, thank you very much for the kind invitation. I think that one of the unique features of rare diseases in general, and Gaucher is not exception, is the needed partnership between doctors, patients, families, and even companies, because many times the patient knows better than the local physician, and also we get a lot of support. Anyway, so I wish I could be live with you, but in these days, the least we can do is have a virtual session. So the topic was selected by the organizer, present and future therapeutics of Gaucher disease in the 3 types. This is my disclosure. Okay, it does not move. Let me see. Important is that each time you see photo of patients is with permission of the patient themselves or the parents in the case of children. If we focus today on the therapeutic aspects, the era of specific therapies began in 1991 with the introduction of the first placental-derived enzyme replacement therapy. And the two distinguished people that need the biggest credit is Professor Roscoe Brady, who was also the researcher who identified the inherited deficiency of the lysosomal enzyme glucocerebrosidase as the etiology of Gaucher disease back in 1965. And almost immediately afterwards, he started to work on the development of enzyme replacement therapy. But as you know, it has taken more than 2 decades before the placental-derived enzyme became a reality. And it would not have happened, and we would not be at that stage so early without the enthusiastic support of Henry Temir, who was the CEO and president of the Genzam Corporation at the time, who pushed to the development of this product commercially, and it was his own voice against the entire board of directors. So since 1991, we always say, and it is a true statement, that we changed the natural history of the disease, we revolutionized the management, which is indeed true. However, on the disappointing side, whatever was achieved in 1991 is still what we have today. In contrast, for example, to other disorders, where in 3 decades, further achievements have been made, but we are stuck with the same benefits and deficiencies of 1991, meaning we have a safe and effective therapy for patients with type 1 Gaucher disease. We have effective therapy for the non-neurological manifestations of patients with type 3. Type 2 are too severe when they are born, unfortunately. And we don't have anything registered for patients with neuropathic Gaucher disease. So they were left aside because there was a consensus that they need high-dose therapy. And until recently, we did not have a lot of efforts. Please note that nowadays there are several companies who develop different treatment modalities that I will elaborate soon, including gene therapy, small molecules. However, 2014, like 8 years ago, was the last time that any new drug was registered. And the new drug by itself does not provide a major advantage besides being an oral formulation over the placental enzyme of 1991. So this is a general comment about present situation and the future will come soon. I also noted that in 1996, we reported the first time the association between Gaucher disease and Parkinson. This has become a very important topic, not just for patients with Gaucher disease, but also for carriers, meaning all the obligatory carriers, the parents, the children, and other members of the family sometimes. It became an important topic in the world of neurology and movement disorders because being a carrier, carrying even one mutation, not having Gaucher disease, but being a carrier of Gaucher is the #1 genetic risk factor for Parkinson. And the Parkinson that is associated with being a carrier of Gaucher or a patient with Gaucher is more severe than what you know as what we call sporadic idiopathic Parkinson. It started at an earlier age, and there is a greater prevalence of cognitive deficiency, like even dementia. And Lewy body dementia is the extreme disease that looks like Alzheimer at an earlier age, and it's due to a kind of Parkinson. Now, I'm telling you this not only to increase awareness. Usually about 20 to 25% of patients with Gaucher will have somebody in the family. It could be a grandparent or an uncle or aunt with Parkinson. I'm telling it now because the good thing about it is two good things about it are: one, that because Parkinson is a much more, it's a common disease affecting 1% of the population over the age of 60, more money is being developed to the treatment of Gaucher-related Parkinson, and what may be good for the Parkinson may be good for Gaucher as well, particularly for neuropathic Gaucher disease, because we are talking about the brain. So maybe It took also almost 3 decades, but by now, I think we expect for the future more companies and researchers to put effort in developing treatment that will benefit patients with neuropathic Gaucher disease. So addressing the lecture today presentation, I had two options. I could delineate the present and future treatments by disease types, or I could do it by modalities. And I thought because many times the same modalities would be relevant both for the neuronopathic or neuronopathic feature, I decided to continue by modalities, and we'll start for each modality, present and future. So I said that in 1991, it was the first time that a specific treatment was available. We do have today more drugs, more specific treatments that they belong to two big groups: enzyme replacement therapy, which basically is giving back what is missing or dysfunctional in our body. And there is another modality of substrate reduction therapy that addresses the glycolipid. You know, Gaucher disease, because of the enzymatic activity, as you all know, there is accumulation of the glycolipid in those cells, macrophage, that are supposed to degrade the glucocerebroside. So if there will be less glucocerebroside, less substrate, then the deficient enzyme will be able to hydrolyze without accumulation, because there will be less substrate to degrade. The enzyme replacement therapy has more than the 3 commercially available enzymes, like in Israel, in the States, Canada, South America, in some countries. In Europe, triglyceride alpha, the third enzyme, is not available, not because it failed to pass the safety and efficacy tests, but because at that time, Shire company got exclusivity for 10 years or so for velaglucerase alpha. It's an interesting story that, of course, the first company was Genzyme, now Sanofi. And when they developed the drug for a rare disease, I don't think they imagined that more companies will join the race. So they did not ask for an orphan status in Europe. So anyway, velaglucerase alpha that came only in 2010 got as if it is the first treatment available, and they blocked the introduction of triglycerides to Europe. But in most countries, many countries, there are 3 enzymes available. And in addition, and I will talk about it later, we see the beginning of biosimilars. So this is, on the one hand, the blessing. We have several options. If one enzyme doesn't work, we can move to the other enzyme. On the other hand, sometimes having many choices can be confusing. And for the specific patient, we talk about individualized medicine, maybe the least, not the most optimal drug may be selected. Now, life became more complicated in 2014, where the substrate reduction eliglustat was approved as first-line therapy. Now, what is first-line therapy? First-line therapy means that this can be the first treatment that the doctor will prescribe for the patient. There are different definitions, but my personal definition for a first-line therapy is the treatment that I would have selected for my daughter or son had they have Gaucher disease. It should be the best, most suitable treatment by means of efficacy and safety. I mean, I would say safety and efficacy first, and then convenience. So there is no doubt that for many patients, taking tablets is more convenient than receiving biweekly infusions. But if the infusion is more effective and safer, in my opinion, it should be first-line therapy. And all 3 currently available recombinant human enzymes, for me, have established a safety profile and demonstrated efficacy in really hundreds or thousands of patients worldwide. So for me, ERT is first-line therapy. There was a lot of there were a lot of discussions and arguments. How can I say something that 50 regulatory agencies in the world thought differently? So I have a great respect to the FDA, to EMA and everything. In this particular topic, I think they have made a mistake, but it's not even important because if a new patient comes to my clinic and he wants to receive SRT, eliglustat, as the first treatment, for him, it's a first-line therapy because he will never get infusion if all goes well. So it's a little bit of semantics, but more of understanding the difference between the two modalities. This is significantly different, and I will elaborate later. Okay, so I already said that the introduction of enzyme replacement therapy in 1991 has revolutionized the natural history of patients with Gaucher disease, and even patients with gigantic bellies, like you see on the left side of the slide, can, if they do not have irreversible skeletal complication, they within years will have like near normal health status. The ultimate success story of ERT, of course, is those patients who started before they developed significant medical problems, like the two brothers, twins, non-identical twins in the photo. I don't remember who is who, but one of them, and this is also an old photo, they feel so healthy they don't even show up for follow-up visit. One of them is receiving enzyme replacement therapy from the age of 4, and the other one is a carrier, and they look the same. Okay, so this is a real success where the morbidity, the problems is only the need to receive infusion, which we also give at home in the convenient time of the patient. So we all know, and I will not, I'll need to speed up to finish on time. The impact of enzyme replacement therapy as far as efficacy is very good for the reduction of the spleen and liver volume, and improvement in the platelet count, in the hemoglobin. White blood cells are usually more normal. There were some issues about dosage, but different doses have been used in different countries by different centers, and the good news is they all work very well. You can see from the left figure that is taken from the very first paper of Roscoe Brady and Norman Barton, where the patient got what we call high-dose therapy of 60 units per kilo every other week, that patients differ in the response. And why not? The disease is so heterogeneous. It starts from totally asymptomatic to very crippling disease. The response to therapy is different by different people. Number 7 is a great responder. Number 3 is not doing so well, but still getting a little better. And he may achieve the benefit only after a longer period of time. So it's not just about the dose. As if high dose is good, the low dose is not good. It also impacts on the bones. And in the early days, when we did not have the MRI sensitive modality to assess the changes that are occurring under enzyme replacement therapy, it was said that it takes much longer for the bones to respond, 42 months. But as MRI-based images became an option, we noted that the response of the bones is also pretty fast, and as early as 9 months. If you look, for example, on the left bottom figure of Elstein et al. From BCMD 2014, we can see that as early as 9 months, many of the patients who received, at that time it was velaglucerase alpha, had 2 points improvement in the bone marrow burden score, which is indicative of a success. And we go to the color figure on the right side. This is the most sensitive bioimage of what is called quantitative chemical shift imaging, QCSI. And this is an assessment of the fat fraction, the ratio between fat and water. And this is a normal fat, not the glycolipid. And when it comes from blue to yellow and green, it's getting better. 0.23 is the ratio that lower than that is considered bone at risk. It was developed by the Dutch colleagues from the AMC in Amsterdam. And you can tell that again, as early as 12 months or even 9 months after treatment, there was a substantial improvement in the status like 0, 22 in the most right bottom. In 9 months, it moved to 0.39. So the risk has been reduced. Now, it should not come as a surprise because if you read the paper by Norman Barton, patient within months after treatment had a significant improvement in the bone pain. Well, the bone pain comes from the bone. How can they not get better? So we, on this aspect, are doing very well. Of course, it's important to start the treatment before the development of skeletal complication. And this is a slide about both efficacy and safety. You see on the left side that even the patient with gigantic splenomegaly, 18 months after treatment, before that she had type 3 Gaucher disease, by the way, but she was limited mainly by the non-neurological features. She could hardly sit by herself at the age of 2 years in the bottom, and 18 months later, she's walking freely with the stent of the infusion. The right side is telling the safety story. You can take it during pregnancy, you can conceive and maintain enzymatic therapy during pregnancy, which is not the case for SRT. And in fact, the results, the outcome of the pregnancy for symptomatic female patient is much better with enzyme than without enzyme. And in the bottom right, we see a father trained to infuse the son, and the home therapy, which is available in many countries around the world. It is very sad when it is not available. Also contribute to the quality of life and the coping with the need to receive an infusion once every 2 weeks. So if I summarize the important point of enzyme replacement therapy today as my first line of therapy, you start before irreversible complication, but not every patient, especially among Ashkenazi Jews. You know, these are Jewish people who came from Eastern Europe. And in this specific population, the disease is not rare at all. 1 out of 800 is affected. This is actually how I could become an expert in the disease, having the world's largest clinic with nearly 900 patients in follow-up over the years. 500 active followed patients per year, 350 on therapy. It gives us a very broad vision and understanding of the disease. And among the Jewish people, there is a mild mutation, so many patients do not need to receive treatment, and it is an art of medicine when to start and if to start. The paradox of choices, I already said before, how to individualize the therapy. Intravenous enzyme therapy versus oral substrate reduction therapy, and then choosing within the category, are all ERTs the same? We know that we still don't have an evidence that even long-term therapy is going to impact on comorbidity. These are other diseases that present in greater prevalence in patients with Gaucher disease. For Parkinson, I'm pretty sure there is no impact at all. For multiple myeloma, which is an uncommon hematological malignancy, there are some hints that maybe it can do better, and more data are to be presented in the future, particularly when big data analysis will come. At the end of my talk, I will say something about the specific excellent registry that exists in Spain, which is not, it's like a national registry that is not in the hands of the company, so it's also an advantage. And as I said in my very first slide, there is no impact yet on neuropathic features for the registered drug. So I took the points I just told you and I show you in pictures. So we start early before irreversible complication. You see the girl from the Dominicans, splenomegaly is improving significantly, but if you have osteonecrosis, collapsed vertebra, of course, treatment is too late. You need to go to the orthoped. Then on the right side is Dr. Tama Dinur from our group, who recently summarized about 20 years of follow-up of more than 100 patients, showing that nothing bad happened to them. And I'm talking about patients that we did not want to treat because they were so mildly affected or asymptomatic. There are some patients who refused treatment, but these are different category. And it's a test of time that we did right by not offering treatment to every very mildly affected patient. How to choose between the modalities and within the enzyme. These are two slides from a paper by Shoshi Revel-Vilk and colleagues, which analyzed all the factors that need to be considered when we're comparing different enzymes. And on the left side, the era of choices, we have an algorithm where we separate between asymptomatic and symptomatic. And in the yellow box, we will, and I say it repeatedly, we select SRT for patients who are unwilling or unable to receive enzyme-replacement therapy. So this is was delineated. And now let's start moving into the new issues. So one new issue is biosimilars. Biosimilar, in contrast to an ethic original drug, is mimicking an existing product. So the company does not need to do a very big clinical trial. They just, the company that developed the first drug has already finished their 21 years of exclusivity. There is no any longer patent protection, and you can mimic the production, but you do more or less the same. So the biosimilar are not identical enzyme, but as the name implies, they are very similar. There is some reluctancy to select biosimilar because you always believe that the first one is better. However, countries who cannot afford enzyme therapy because of the high cost, when they offer biosimilar, it's a good option. And I met a case from one of the Latin American countries where the family was reluctant to start therapy only because they wanted the particular one of the three existing commercially available enzyme, but available not in their own country. And they delayed the beginning of treatment only because they refused biosimilar. I think it is a mistake, but obviously more information is needed. Global registry will help, and but it plays a role. And we can see that papers supported by specific company may sound a bit negative about biosimilar, but I think we need to keep an open mind. And coping with extraordinary expensive treatment is a significant problem. So this is a comment about biosimilar. We can change the regimen of administration. In the case of velaglucerase alpha, because it is the least immunogenic drug, that means fewer patients have developed anti-drug antibodies, fewer patients have suffered from hypersensitivity reactions. We conducted a local investigator-initiated research that was sponsored by Shire and later Takeda, where we demonstrated that for this particular enzyme, you can gradually reduce the pace to 10 minutes. Now, I'm not telling you to do it 10 minutes. It was in a context of a research, but this research has been going for more than 5 years. And in Israel, we have a special permit by the Ministry of Health under a patient name basis to accelerate the rate. The patient love it because they like to shorten the experience of getting the infusion. This was one new story that I can share with you because you didn't ask me to talk about things that everybody knows, so we start to give some new stuff. Q4 is giving the entire monthly dose at one time. It was tested for imiglucerase a long time ago. For whatever reason, it did not gain popularity because the performance was a little bit inferior to the biweekly. However, it is interesting. Some of my patients want to go to liglustat, but there are some concern about taking other medications or other concern, like a female patient that may want to become pregnant. So if they are really fed up with infusion after 20 years, why not give the infusion less frequently? Think about it. You saw this patient with gigantic spleen. Does it make sense to you that the same dose that was needed to reduce the size of the spleen is needed when the spleen is already near normal and all the parameters are within the normal range after 20 years of treatment? It makes sense that you can either reduce the dose or maybe increase the interval. But again, I give it to you as a thought for future studies. Then there is another interesting story by trying to randomize the administration. Usually as doctors, we educate the patient, take the pill very consistently and be compliant, but there are some suggestions that randomization may also be of some use. I will not talk about it now. Combinations. This has been addressed already when the first substance reduction therapy, miglustat, was studied in the late 90s, early 2000s. I used to say that for the majority of the patient, there is no rationale to add another treatment when everything is fine. When things are going bad, very rare cases that have developed massive lymphadenopathy or lung complication while on enzyme-replacement therapy, I thought you can change to SRT, but some people think maybe do a combination. But it needs to be studied. We studied the combination between enzyme replacement therapy and ambroxol, which is the pharmacological chaperone I will discuss very soon, in patients with suboptimal response. So the patient has been at least 2 years on the drug, the platelets are still low, the bone density is still bad, or lyso-Gb1, which is a specific biomarker that reflects risk for complications, is greater than 200. Instead of increasing the enzyme dose, we add a different modality that is very safe. Ambroxol is actually a cough medicine available over the counter without prescription, but we do give it in a higher dose, so it's in a setup of a clinical trial. We'll come back to it. These are, as I write in the title, present and future. Present because the drugs are here, but also future because more research needs to be done. And unfortunately, with such a strong presence of the big pharma companies, they do not necessarily encourage additional clinical trials. So again, food for thought. Moving on to the future and to address some of the burning questions, I already mentioned to you that ERT and SRT do not impact on Parkinson, but they may impact on myeloma. There have been an animal model that's showing some benefit for eliglustat. There have been a couple of case reports that enzyme replacement therapy with velaglucerase alpha, but it could be another enzyme, had improved the indices of myeloma in single patients. Recently, we collaborated with a young hematologist from another hospital on a patient that had both Gaucher and smoldering myeloma. And we said that enzyme and SRT at the moment does not impact on neuronopathic Gaucher disease. So here in the future, and remember, we're talking now about enzyme therapy as a modality. There is a group in Canada led by a neurosurgeon by the name of Neil Lipsman, shown here, that is considering giving infusion. They are using imiglucerate, Cerezyme, to carriers of Parkinson, but at the same time, it can be given to patients with neuropathic Gaucher disease. This is a very new modality, highly experimental. Only maybe 3 or 4 patients tested it, but there is a sophisticated ultrasound machine that can induce a temporary opening of the blood-brain barrier. This protects the brain and prevent the entrance of big molecules like enzyme to the brain, but you can open it with a low intensity focal ultrasound. You may want to read about it in the future. It is just a hint that, as I said in my earlier slides, things are starting to happen with neuronopathic Gaucher disease, but we are not there yet. This is distant future. Another future option for enzyme replacement therapy is oral delivery. We did it with the company, Israeli company Protalix. That is the company that makes the first plant cell-derived human recombinant enzyme, and they're using carrot cell to produce thylaglutazone alpha, which is commercially available in many countries, and they are using tobacco saline to develop a drug for Fabry disease, which is not yet approved for marketing, but has very promising data in phase 3 clinical trials. So because they made the enzyme in carrot cell, we thought that if you just take the carrot cell, normally you grow the carrot cell, then you need to lyse them because the human enzyme is within the cell. But if you don't lyse them, the plant cells have a cell wall with cellulose that does not allow the acidic degradation in the stomach. So when the patient drink it, it looks like a fruit shake. It actually reaches the small intestine and it gets to the target organs. Unfortunately, the company stopped developing it. I've been begging since 2014. You see here data I presented at the World Conference in 2014. What you see basically is that if in the rats and pigs we could sacrifice the animal and demonstrate the existence of thylaglutazone alpha in the spleen and in the liver, in the human subject, we just measure the increase in the enzymatic activity over baseline. So I believe that one day somebody will come back to it, and it's a very friendly way to receive enzyme therapy by drinking like a fruit shake, as I said. And also, you don't need to get a big dose every 2 weeks. You can take it on a daily basis, which is more suitable for a housekeeping enzyme. What is housekeeping? Is enzyme that we need it around the clock, not every 2 weeks. And Ed Gins, who was also one of the pioneers of development of enzyme therapy, originally he was with Roscoe Brady, and then he was his independent group at the NIH, has an idea to use bakeries to actually a foodstuff as a carrier of proteins or genes, but this also is promising. Ed Gins is still in the mouse level, Protalix in the human level, and both projects are not being developed right now, but they may be some nice modality in the future. Now we need to go to SRT. And I already said that the idea here is to reduce the amount of the glycolipids so the deficient enzyme will not have too much work to do and there will be no accumulation. And there are 2 drugs in the market, miglustat, Zavesca, and liglustat, Serdelga. Miglustat was approved for mild to moderate patients who cannot take enzyme and like second-line therapy. And the liglustat, as I told you, was developed as first-line therapy for individuals who don't have ultra-rapid metabolism. If the drug is metabolism so fast in the liver, you will not achieve a drug level that will be effective. But forget miglustat and liglustat. Substrate reduction therapy as a modality means that if you look at the upper left corner, glucocerebrosid is basically made by addition of glucose to the ceramide, the sugar to the lipid, by a glucocerebrosid synthase, an enzyme that makes it. When we partially inhibit this enzymatic activity, less glucocerebrosid is being made. So in the future, when the reaction will go in the other way, there will be no accumulation. But the glucocerebrosid is the first committed step in the synthesis of hundreds of glycolipids, most of which we don't even know what is the role in the body. So I say in my lectures, and I give it to you as well, I'm not a religious person, but you cannot understand the entire universe and the creation of man. If God has created more than 400 lipids, I ask a lipid biochemist how many lipids are inhibited by miglustat or liglustat, and the number goes between 400 and 1,000, meaning nobody knows exactly. But we have a minimum of 400 different molecules. It makes no sense to me that we should reduce their content without any concern for the future. So forget all the data from the clinical trial, real-world papers, and so forth. As I say, if my daughter had Gaucher disease, I would like to give her enzyme and not SRT. Of course, there are patients who cannot take enzyme, for which is not suitable, who prefer to take a risk than to suffer the needle. It's legitimate. It's registered. It shows efficacy and safety in well-designed clinical trial, and I do prescribe it to my patient. But I prescribe it myself to patient unwilling or unable to get enzyme because of the modality. Now, when we talk about specific treatment, we also have learned that elaglustat, for example, has a more problematic safety profile. And this is why on the left side, you see the algorithm, how we treat Gaucher disease in our unit. And you see on the right side, an algorithm from a group of KOL, key opinion leaders in Europe, led by my friend and colleague, Professor Nadia Belmatov, where you see that a new patient, the first thing they say here, we likely comply with oral therapy because you need to be compliant, taking 1 or 2 tablets a day. If no, you go to enzyme. You need to be with a suitable genetic metabolism status. If no, you go to enzyme. Then you need not to be pregnant, not to play, not to do breastfeeding, not to suffer from gut problems, not to suffer from cardiac problems, not to suffer from kidney or liver problem. If you suffer from those, you need to get enzyme. If not, you can take the elaglustat. So what do you understand here? You understand, first of all, that there are a lot of if and if and if and if that does not exist for most of the people on enzyme therapy. And besides, you see that these KOLs use Serdelga as first-line therapy for patients with type 1 Gaucher disease. And if you read a paper by another colleague of mine from the United States, Professor Manisha Balawani, you will be surprised to see an identical algorithm in a paper from 2016, only without the colors. Okay, with this said, I want to tell you that my concern about elaglustat are summarized here. The first point is the modality, and the second is had to do with the clinical trial development. And when I analyzed the data of for example, of the ENGAGE study for naive patient or ENCORE study for switch patients, the data are not as good as with enzyme replacement therapy. And the definition of maintaining stability rather than lack of deterioration is also problematic. And the company has never been willing to address the question, how many patients would have been summarized as failure if we use the criteria of deterioration in the other clinical trial. In fact, in miglustat, it was 5%. So there was a lot of emotions. I don't want to go too much of it. You see here in the table that when we switch from Cerezyme to Vipriv, if the patient had more than 1 gram% reduction, we had to stop and it would be a deterioration. In the study of Serdelga, switching from Cerezyme to Serdelga, up to 1.5 gram%, it was considered good, maintaining stability. It's getting crazy with the spleen. For Vipriv, we were not allowed to observe more than 15% increase in the spleen volume. And by the way, 0 patient had deteriorated in the clinical trial of Vipriv, for example. And for Serdelga, you can increase the volume of the spleen by 25%. And I'm telling you, it never happens if you stop treatment at all. And look about a decade before, when we did the switch over, the very first switch over between enzyme and SRT was a single center in our unit. And here the definition of failure was 5% from baseline. So I urge you the doctors among you to read the paper from Blood that is shown here. And for the others, just to keep an open mind and try to build your own opinion on the story. Okay, now we go to the future of SRT. The future of SRT would be, first and foremost, a drug that will reach the brain, that will cross the blood-brain barrier, because until now we have nothing for neuropathic Gaucher disease. So Sanofi is developing venglustat. It's another friend of elaglustat, but it can cross the blood-brain barrier. And as we speak, there are clinical trials in patients with type 3 Gaucher disease. And we have some encouraging information in different meetings. However, The same drug was also tested for GBA-related Parkinson and was stopped by the FDA. It was a placebo-controlled trial. We were not informed why the treatment was stopped, but my understanding is there were safety concerns in the Venglustat treated arm versus the placebo-treated arm. In May, we had a big meeting of the International Working Group on Gaucher disease. It's a IWGGD instead of EWGGD. And we had a recorded lecture by a doctor from the company who did not answer questions. So I think it's good that there is a study. We need to be concerned about safety because in the adults it was problematic. Professor James Sherman, who is the scientist behind Serdelga, is also concerned about the current available SRT, and he is working with his own company to develop new molecules that will be more safe, more effective, and reach the brain. We know that active research is taking on, which is good news that there is research by that. Then I mentioned a pharmacological chaperone. Apparently, Gaucher disease is not just a glycolipid storage disorder, it's also protein misfolding protein disorder. That means that the mutant enzyme 3D structure is not correct. And because of that, several things can happen. One is that the quality control of the cell will get rid of this faulty protein, and less mutant enzyme will reach the lysosome, but it can also get stuck within the endoplasmic reticulum. This is the organelle where the protein is assembled from nucleotide to amino acids. And when the misfolded protein is stuck within the ER, one of the consequences can be what our scientists call ER stress, inflammation, fatigue. It also may be the relation to Parkinson. So molecules that can improve the misfolding will allow the protein to bypass the early degradation to reach the lysosome. And even though it's a mutant protein, there will be more of it to degrade the substrate. And there is a proof of concept, and I don't have enough time to tell you, but the nice thing about it is that it is, you see here Don Mehoron, he was disappointed where the first clinical trial of isofagamin failed. So he screened 1,000 existing drugs to find those that have the chemical structure that can work as a chaperone, identified 12 drugs. One of them is Amboxol over-the-counter drug, so this is advantage. About 10 years ago, we did a proof of concept kind of study. It was actually an off-label administration of 150 milligram, which is a cough dose, to 11 patients, and we had only 2 responders, which were the thinnest one, which fit what Don told us that we need to go for higher dose. And Professor Kusako Ono in Japan, as his successor, Dr. Aya Narita, you see her with me in the left bottom part, took the idea, and since Amboxol crosses the blood-brain barrier, they gave it to patients with neuronopathic Gaucher disease. And here there is a great news that it works for quite a few patients with actually a reversibility of myoclonic seizures and other features. Sorry. Okay. So there is a clinical trial in Japan for neuronopathic Gaucher disease. And very recently, apologies, there is a paper from Germany about an infant with type 2 that was born with ichthyosis who got, this is a girl who got high-dose Amboxol from early life, and she's doing much better than any other type 2 patient ever participated in any clinical trial. So I think Amboxol is very promising compound, maybe also in the context of Parkinson. Now, Jolene Esteti from our group has started to organize a registry for Amboxol because the existing registries of Sanofi and Takeda were not willing to to collect data on Amboxol. And many doctors, for example, Italian doctor who has a patient, 6-year-old with myoclonic epilepsy, I advised her to give Amboxol because there's no another alternative other than anti-epileptic drugs. And she said, why there is no more data in the literature? So we need to create it because we don't have a company that is pushing for a generic drug. So, okay. We are about to finish soon. So among the therapeutic modalities is gene therapy, but since my colleague is presenting it later, I will only say that it's fantastic to have this idea and dream to cure disease by one-time introduction of a friendly virus that contains the DNA, the gene of the human protein. We have done in Israel 2 compassionate gene therapy for type 2 Gaucher disease. These toddlers lived longer, but the quality of life did not justify the exercise. One is died, the other one is deteriorating, but the safety of the procedure was demonstrated for these 2 infants. There were some safety concerns with the same drug administered to GBA Parkinson, and this clinical trial is currently on hold. There was an idea about doing ex vivo, but I leave it to the next speaker. I just want to say that it's nice to know that we think far ahead, but this is not going to be a commercial treatment in the next 2 or 3 years. So what to do with type 3 Gaucher disease? I already hinted it indirectly. Treat the non-neuronopathic features like type 1 Gaucher disease. Add Amboxol, particularly if there are myoclonic epilepsy, ataxia, or other neurological problem. And if everything fails, consider experimental therapy and don't forget supportive care. So I've been working on Gaucher for 30 years. What can we expect for the future? I really don't know. The last 30 years, as I told you, we are kind of stuck in the achievement of 1991. And we hope that we will cure Gaucher disease better, all 3 types. We want to have an effective treatment for neuropathic Gaucher disease, even better to prevent it. And we also need to remember that even what we have today is not available to many patients in countries like Afghanistan, Pakistan, Bangladesh, India. And we need to show solidarity. And if the companies are making so much money in the Western countries and wealthy countries, they should increase the compassionate therapy in those countries that have not been blessed with those resources. And with this, I want to thank you for your attention. And again, I must say a major congratulations for Professor Pilar Giraldo for also, I think we also share 3 decades of experience. She has been so creative and she has many, many important contributions, one of which is the National Spanish Unbiased Registry. And thank you for the attention, and I apologize for talking too much.
Muy bien, acabamos de ver pues esta completísima.
Thank you very much indeed. We've just been listening to this very complete review of our professor. It couldn't be anything else, could it? And so important because of his clinical experience. And he's somebody with an incredible, huge scientific basis, but also human contact is essential. So one has to speak from experience. And this is the reason why we are here and the reason why we are physicians, really. With no further ado now, we shall continue with today's program. And we have a very interesting subject now. We're going to be hearing about the gene therapy that's not so much the future. We could talk about it being the present, but from the standpoint of a patient who has had the experience. Now I shall give the floor then to Chandra McLean from Canada.
24th is a big day for me because potentially this could be my last infusion that I've been getting for 29 years. And we're doing it. We're going into it. I think it's gonna be a really good end to a saga, maybe? I think it's gonna be fantastic. But okay. Let's do this, guys. Let's do this.
Hi, my name is Chandra. I'm a board member for the National Gaucher Foundation of Canada and fortunate enough to be the first recipient of the AgroBio gene therapy for Gaucher disease type 1. That's exciting. Thank you all for having me as a guest speaker. I'm excited for this opportunity to share my personal experience in this gene therapy trial to help increase awareness and put a little hope back into this world. I'm an introvert at heart, so I don't expect to win any awards for public speaking. I have some handy notes to help me along here, if you guys don't mind. I would love to start on a very positive note. July 2nd marked my second year of my 2-year milestone of my stem cell transplant. And to my understanding, if I were to be tested for Gaucher disease, it would not be detected. And I have been living treatment-free without infusions for 2.5 years. I still have to pinch myself. I feel these past 2 years have given me some time to look back and reflect on my experience, and also to process what the heck just happened. What I mean by that is for 30 years, living with a rare disease, the struggles and traumas that can come with that, coexisting with an invisible illness, to now, dare I say, normal? And normal is not a word I ever strive to be. I've been asked many times, what made you decide to participate in the new gene therapy trial? My first thought wasn't, wow, what a life-changing opportunity that could potentially improve my quality of life. No, or how could I not? No, my thought was, my first thought was, wow, what a life-changing opportunity that could potentially improve so many lives. How could I not? When you've been diagnosed with an incurable disease like I have, you live your life on bi-monthly enzyme infusions and endless doctor's appointments. Never in my lifetime did I think that something would come along that would allow me to live and thrive treatment-free. Stem cell therapy was science fiction at best, and how could it ever find its way to my tiny rare disease world? A magical dream only existed in wishful thinking. But sure enough, there were whispers of new gene therapy in its stages being introduced into the lysosomal disease family, such as Fabry disease and Gaucher disease. And it could soon hit the medical community mainstream. Then in 2019, at an NGF conference in my hometown, I first learned that my magical dream and wishful thinking were coming together. The initial patient requirements was the ideal candidate to be male, between the ages of 25 and 30 years old, and stable on enzyme replacement therapy. I laugh to myself now, just how casually I asked my doctor, hey, if you need any volunteers, sign me up. I didn't have the male requirement going for me, but I had all the other requirements were there, and I was willing. 1 month later, I was getting my infusion done at a clinic. I can recall my doctor and 3 nurses were there at the same time, which was quite an unusual occurrence. They said, hey, are you still interested in participating in the medical trial? Because nobody so far has volunteered, and you've been the only one so far, and AvroBio has approved a female participant to take part. What do you think? Take some time to think about it. It's a big decision. I want to say that I thought about it. I weighed out the pros and cons, but before that infusion was over, I was signing a large stack of papers that would drastically change my life, the direction of my life forever. After what I felt like signing my life away, now seemed to be on fast forward. Looking back, I'm so grateful my medical journey started at such a young age. My experience with hospitals, copious amounts of doctor's appointments, tests and needles, etc. throughout my life, I believe has helped set me up to face medical unknowns that would await me in this trial. Since I felt a bit of a seasoned medical guinea pig, if you will. Don't get me wrong, I didn't go into this trial with zero apprehension. I definitely had my concerns, and friends and family did as well, as it was a brand new trial, and there was no guarantee of a positive end result. And no other person who had already been through it could tell me what to experience or what to expect. We were pioneering a new map to a journey unknown. I haven't been on social media for years. It can be very overwhelming and sometimes not a positive place, but it's still a very fantastic platform for sharing information. When I was accepted into the AvroBio trial, I felt such a pull to share this incredible news, to shout it from the rooftops that, hey, there's hope. There's hope out there on the horizon for the rare disease community. I felt it was important to spread awareness to other Gaucher patients, their families, and whoever else's information could benefit. We created and posted funny, entertaining countdown videos of smashing eggs, numbered with the 12 days left until I was to be admitted into the hospital, hoping to bring laughter and joy to the situation. From this, my support grew, and it had a much greater ripple effect than I could have ever imagined. The abundance of love and support that poured in every day still makes my heart so full. And it's such a great realization as well, just to see how many people and families this trial could help if it was successful. I couldn't help but to think, well, no pressure, right? Since the trial was in its beginning stages, there were a lot of loose ends to be tied up. And for example, what I mean, because it was originally for male participants, sperm collection was included in the participation, but egg collection was not. This is when I learned that I needed to advocate for myself as a patient. I included not only myself, but any future female participants to have egg collection storage included. Also to have the same benefits any male participant who may have their reproductive health affected due to the effects of chemotherapy in the trial. The trial is very, sorry, I'm lost here. I don't have the chemo part. Chemotherapy. Sorry about this. Okay, sorry. The trial is extremely physical on the body and also hindering the mind, the health of the mind. I feel like a healthy body. I feel like a healthy body. I feel like a healthy mind helps a healthy body, just as a healthy body helps a healthy mind. Sorry, that was a mouthful. I felt that going through something of this magnitude, I should consider physical therapy for my body and my mind too. And I'm happy to say that now agreed to include an option for mental health as well. Importantly, this is your experience. Mental health and fine print can easily be overlooked, as it is it is important as a patient to advocate for your needs. Your voice can make a difference in not only your health, but others as well. Moving forward, everything to start get more real. The testing and appointments filled about 3 months of my calendar to verify my baseline health, to officially qualify me as a healthy candidate for the trial. My eggs were collected and frozen. I felt like I've given enough blood to donate to a small country. I was given GCSF injections to take home. This was meant to supercharge my body's production of white blood cells in preparation for stem cell collection. This medication had very unpleasant side effects for me, causing some of the most excruciating migraines of my life. And it was a reminder that the trial wouldn't come without difficulty, ultimately would be worth it. After 3 rounds of GCSF, I was to have apheresis, a process to collect traffic-jammed white blood cells from stem cells that my body just produced, and taking away the GCSF side effects along with it. So many appointments and various blood works passed the time quickly, and before I knew it, I was checked into the hospital. Time to check into the hospital. I knew I was going to be there for a while, so I packed a few items from home and some of my favorite snacks to feel more comfortable and less like a hospital to prepare my mind for chemotherapy. When the word chemo is presented, it can be ominous and scary, and it is used with intention to destroy cancer. However, what helped me, for each round of chemo, I said affirming words like, "Thank you for healing my body," and I imagined this IV bag full of poison was instead fresh spring water that was cleansing my body for fresh soil to plant these new life cells. But boy, did it ever kick my ass. After a few days of chemo, I was taking long walks and exploring the hospital. I was even enjoying some sunshine and blowing big bubbles on a nice grassy hill behind the hospital. I thought to myself, hey, I can do this, no problemo. But it was maybe days later that I was weighed down by the effects of chemo. By less than a gentle reminder that my body was working very hard for its new cells. The transplant itself was anticlimactic, considering the miracle that was taking place. 10 minutes of my stem cell reinfusion felt very surreal. They hung an IV bag of my newly modified cells. And I just simply existed for a while the room buzzed with doctors and nurses. And moments later, they were gone. And now what? Physically, I didn't feel any different. I did experience a grieving process of me, that I was saying goodbye to. My life's greatest and most influential teacher, I'll call Gaucher disease. And welcome to a freshly new planted cells into a part of me that I haven't met yet. The next week that passed, my body was trying to process its new genetically modified cells. And we watched the numbers of my blood work change daily as the nurses wrote them on a whiteboard in my room. These small numbers were our only indication that would tell us the gene graft would take. We watched them anxiously with my old cells on emergency standby. I remember experiencing pure exhaustion, but also extreme restlessness. There was a revolving door of nurses and doctors and staff, everybody doing their part to keep this amazing trial on its tracks. Throughout the healing process, some days I only had energy to shower. And even when it was time to go home, the recovery process seemed to be the most difficult, tedious part for me. A flu that's deep in your body and seems to last for months. And honestly, there were even days where I'd question my decision of putting my body through this. I was also told it would take about 6 months for me to consider to go back to work, and a year or two for me to feel 100% again. In many aspects, I was practically a newborn. I had no hair. My skin was sensitive to the heat and the sun. Ketchup was somehow spicy. And my beloved coffee tastes like dirt in my mouth. All 5 senses were 100 times more sensitive, and the world around me in every way was different. Everything was different. The experience was the toughest life challenge that I could have ever signed up for. I really felt what it is to be proud of myself and to be a proud woman. And I've had so many strong people supporting me. If I were to suggest a crucial part of doing this treatment, please make sure that you have a support system. I wouldn't have been able to finish mine without the help and strength that was provided to me from my support system. Yes, it has been an exhausting and slow recovery, but when I look in the mirror today, I see exponential progress. I have so much appreciation for my new energy levels. I'm able to complete a long day of work, 12-hour of physical work, infusion-free. This trial has completely changed my life, and I am so entirely grateful. One of my biggest reasons for doing this trial was my dream to travel, having more time and freedom without planning around infusions. I have experienced life as a person with a chronic disease, which has now evolved into a whole new experience that I'm still getting to know. Sorry, I'm just gonna drink here. I'm moving beyond my comfort levels and able to do great things, like being able to share this wealth of information with everyone. This trial has taught me more lessons in vulnerability and definitely more in humility. The ongoing impact from this experience is the connectivity. 2 years later, and here I am in Canada, connecting with all of you in Spain. To be able to be a beacon of light to anyone who feels hopeless, I'm your someone. You're not alone. And I hope that my struggles can help your struggles. Anyone who lives an infusion life knows the headaches that can arise, especially what are called orphan drugs for rare diseases, are often expensive and not covered by governments or insurance, so funding can be very challenging. Finding access to proper infusion clinics that are local to you, or having properly trained nurses that can administer your medication at home, it still commands a lot of time and energy out of your life. Worse yet, not having access to your life-saving medication at all. Going through one difficult treatment to be infusion-free can really make the difference. I wanted to tell my journey as if I was the one listening, or if I had a child or loved one with Gaucher disease and wanted this information. I wanted to connect on a human level as opposed to a medical level. as if you were hearing it from a friend instead of reading it data in a medical journal. As of now, I know 2 other participants who have successfully completed the trial and can't wait to see. I know of 2 other participants that have successfully completed the trial, and I can't wait to see how this continues to benefit the Gaucher community and beyond. So to my fellow rare warriors, I'd like to end with this. With everything going on in this wild world, let's show up for each other, without judgment, with acceptance, and together we can learn to celebrate each other. With or without a rare disease, be authentically yourself. You'll never know who you inspire. And lastly, a big thank you for inviting me to speak today. I am honored to share my story, and I hope it can inspire others and be a beacon of hope for the rare disease. Rare disease is everywhere. I'm happy to answer any questions that anyone may have after this presentation. Thank you.
Thanks so much. Si os parece, seguimos con la siguiente ponencia. Muchísimas gracias.
Thank you very much, Chandra. It's been very enriching, and as a physician, I keep on learning so much. So really moving. Thank you. I love it when technology is good for the patient, and this is something we have achieved here beyond molecules and other things. It is true that we need to really thank you for your contribution. And now let's keep on with the agenda. We will now move to a different geographical location, also within the Gaucher world, and let's listen to the experiences and opinions by Alejandra Tornero from Argentina's Gaucher Alliance. She will tell us more about the concerns. I would focus on this, on the concerns and needs of Gaucher patients. As Dr. Simran said, Gaucher patients are very heterogeneous. It is very difficult when you talk about Gaucher to generalize, but I am sure that there are many common concerns among all of us. So, Alejandra, the floor is yours. Thank you. Hello, good afternoon to you all. Before I begin, let me say that I really admire Chandra for her testimony. What she has gone through has not been easy at all, and I am extremely proud of her energy and her bravery. She has been extremely successful, and I'm sending her a big hug from here. First of all, I would like to thank the MPS Lisosomales de España, the opportunity for participating in this webinar. I apologize for my voice, but I have a big cold, so my voice is really altered. My name is Maria Alejandra Tornero. I live in Argentina. When I was 5, I was diagnosed with Gaucher disease. At that time, I was simply a person with a rare disease. That's what we were called at that time. We call them now unfrequent diseases and not so much rare diseases anymore. So the first few years were normal since birth until I was 5. And then I became more and more aware about my body. I didn't have much complications at that time, but so I went through these first years in a normal way as any other child. I had a mother, a father, an elderly brother who was 5 years older, and a younger sister. Of course, at that time, she wasn't born yet. Besides, after 5 years of age, my mom started to realize there were some dermatological manifestations, mouth bleeding, nose bleeding. I was left without, well, without air, without breath. My spleen was very big. It had grown and it pressed against my diaphragm. That's why my mom started to look into it and to go to pediatricians. And I was referred to a very important hospital in the city of Buenos Aires. And that's where I was diagnosed with Gaucher disease. What was done at that time once you got the diagnosis? Well, nothing. We're talking about 1975, roughly. And at that time, there was a hematologist who was able to make the diagnosis through medular punction. It was the only way. And the only thing that they had were hematological, well, blood controls every so often and nothing else. The physician was not even given, was not even able to explain exactly what this disease was because there wasn't much information about it in our country. Here, I started to feel that there was something wrong in me. I was tired every day. I would wake up tired. My bodily constraints were increasingly bigger. I couldn't do, for instance, physical activity at school. I couldn't do any sports. I couldn't swim. If I went on holidays to the beach, the doctor told me, well, try not to have her in front of the waves because maybe if she gets hit by the wave, she could have her spleen bursting out. So there were bigger and bigger implications. I would try to keep my life as normal as possible, of course, with the assistance and care of my family, and I grew older until I came to my teenage years, which more or less went on with a certain degree of normality. After my controls, of course, I went through different hematologists. First of all, I went to pediatric hematologist and for adult hematologist. But every time we left the doctor, we realized we didn't have information. We weren't told exactly what the disease was about, but we knew that the spleen and the liver were bigger and bigger, and that I was having more digestive problems. I had lots of. I was taken to hospital several years to control infections that I had in my bones and so on and so forth. But doctors were not able to piece together the puzzle. I was getting separate diagnoses, gut problems, bone problems, and so on, as if it were different people. And they didn't realize that all of the symptoms and complications were a result of Gaucher. So I was increasingly getting thinner and thinner, as you can see in the pictures. And despite you don't see there, my abdomen was bigger and bigger. My and what I was what I had more trouble was in digestive, because if you have a big spleen and liver, well, digestive issues become a problem. So if I drank a glass of water, I would puke. I didn't tolerate anything. There was more and more fatigue. Platelet counts were down and down until we eventually found a hematologist when I was already married, and he decided to remove my spleen because I had problems with platelets and red blood cells. The values were so long, I couldn't even carry a normal life. And at that time, when they removed my spleen, I was 20 years old and I was weighing 23 kilos. So for a normal person, it wouldn't weigh even half a kilo, and my spleen was 20 kilos. So imagine what it meant. Besides of all the difficulties and the disorders it meant. So We now know that removing a spleen is not a good idea, but I had my doctor's authorization eventually to have to get pregnant. I had my first child when I was 22, and after having my first baby, my daughter, I wasn't told about this at all. What happened after that? One vertebra and one dorsal lumbar vertebra was completely dissolved, and they had to replace it with a small part of my hip bone, and I was given a bar. I was placed a bar in my spine with a prosthesis that I still have in my spine. And after all of this, it was known that after so many years, until they met with specialists, of course, having had a pregnancy without having received uh, uh, ERT or any treatment about it, well, my pregnancy took up all the calcium in my body. And I don't know if you can see that, but I had two operations. That's why in my spine. That's why I have such a short hair there. And that's why I was very tiny, very weak, very small, and that's how my life went by until I finally mothered three children. After the third child, when my older brother was diagnosed with Gaucher, he had a liver infarct, and when he was taken to hospital, he had some enzyme tests. In Argentina, you don't need to have a medular puncture now. It's quicker and less painful for someone to have these kind of enzyme tests. And I was asked to take something to, well, the papers with my brother's analysis, and they opened the doors to me, and it was one of the laboratories. And without realizing, by chance, I got to know the therapy that had just reached Argentina. And that's why for the last 22 years, I've been receiving enzyme replacement therapy, and that has radically changed my quality of life and my body. I think all adult patients with Gaucher could write a book about their predicaments throughout our lifetimes, because this is what happened in the past. You were either lucky or not to find a specialist doctor who would be knowledgeable about Gaucher, and that, but, and that, and well, maybe sometimes you were able to find the things you needed, sometimes you weren't. It was all by chance. It is true that some people might suffer a little bit for enzyme replacement therapy, but I am grateful to life for receiving this therapy every 15 days. That's what makes my life possible. I am a mother, I am a teacher, I work in the morning and in the afternoon in a kindergarten, and everything I had to go through life for so many years is now gone. I'm now 53, and that's why 3 years ago I created the Lysosomal Alliance of Argentina for people with Conte, Gaucher, and Fabry diseases, because, well, our generation has a more comprehensive view of our disease. Now we find doctors who are specialists in these diseases who can diagnose us and so on. But for future generations, we need to make sure that they are diagnosed as early as possible. We need to make sure that they can have the necessary treatment once they are diagnosed as Gaucher patients, and so that they don't have to go through operations and internments and all the complications that appear due to the disease when they do not receive the treatment on time. This is my family, my parents, my brothers and sister, my husband, and my children, and thanks to them, and to the huge family that I have, because there's plenty of us. I am extremely grateful that I always had everybody's support to go forward. Sometimes you go through difficult stages. Sometimes things happen. Sometimes it's not easy, but you're able to overcome. If you have this will to live and to overcome whatever problems happen, these are benign diseases. They have a treatment. It is extremely important, and everything depends on whether they are diagnosed early so that we can have a more or less normal life. Everything changed. The quality of life of those who are treated do does change, and it is important that physicians who look after us are knowledgeable about what we need. Thanks to the fact that treatments exist, I can do everything I can do at the moment in my life, and that's why I'm so ever grateful. That's why the message that I would like to throw to those who have treatments available, but they are not compliant, well, let me tell them that it is very important, because access to treatment is not easy in our country. Even if we have a law, 26,689 on rare diseases to promote the well-being of persons with rare diseases and to improve their quality of life and their families' quality of lives, there are some delays, administrative delays, and this is not helpful for compliance because people cannot have an ongoing treatment as they should. And this is what we are currently suffering for. We also need to have a register for uncommon diseases. This is the biggest challenge for us all, to have this comprehensive registry where patients' organizations and all of us can really understand how many patients for each pathology there are in our countries, because this would entail the obligation for decision makers, for those who have the power in our healthcare systems. They would know how many people they are damaging when these treatments are not available on time. Because sometimes people don't realize the complications that these diseases entail when treatments are unavailable. Very often the cost is higher when having to deal with the complications that need to be urgently solved than the treatment itself. Another important barrier is early access. We have a law for neonatal screening, but for very few diseases, and that's why we are working on screening to include lysosomal diseases, among others, so that we can have earlier diagnosis and so that we can treat them on time and in due form, because the early Gaucher patients are treated, the better their quality of life will be, right? We all know that. My apologies. I am looking at my notes. I didn't want to forget anything. The biggest challenge for us is to have multidisciplinary teams and able doctors to do monitoring of all the patients who live throughout the country. We need to be closer to the patients. We're living in a very large country, and patients are scattered. Some of them live in very remote areas, others live in big cities, but they all are entitled to treatment without having to travel hundreds of miles. The most specialized hospitals are located in a specific part of the country, and not everyone live there, so not everyone have access to come close to those specialized hospitals 100 kilometers or hundreds of miles away, where they could be treated for their diseases, right? So we at the Argentinian Lysosomal Alliance, we have a program sponsored by a company is precisely this, to be able to go to the hospital or to a healthcare center to talk to the doctors and for all doctors to have the information about what Gaucher is about, so that everyone with a Gaucher disease are aware of what is the closest specialized center, the one closest to their homes. They need to know that close to their homes there are doctors where they will be able to understand what they have. They'll be able to get treatment. They will be able to give them follow up, and they will not need to travel thousands of miles away or hundreds of miles away. We all Gaucher patients need multidisciplinary teams, not only a traumatologist and a hematologist, but rather we need multidisciplinary teams who have patients, who place patients at the center, who work for the patient, because all of us are individual persons with our own diagnosis, but every one of us carry our disease in a different way. So the idea is not to have a single opinion of a single specialist, and because very often they might be suffering complications in different parts of their bodies, because we know that Gaucher disease is a multi-systemic disease. It does not affect a single part of your body, but many. We often have silent symptoms, but the disease is indeed showing up. That's why it is so important to do this field work across the country. Again, we need to be extremely grateful in Argentina because all children and adults diagnosed with Gaucher disease have been benefiting for over 20 years to receive uh, i- home infusions, and that is extremely important. If you have any doubts, don't hesitate. That's the best thing that could happen to us during the pandemic. We didn't have to suspend our treatments because we couldn't receive our infusions at the hospital. We had the infusions at home with all the necessary care. Of course, those who had the medication, because access to medication at that moment was more difficult. That is also true. But for nursing, we had the same service as ever. We didn't have to suspend the infusions during the pandemic, and that was extremely important for those who work and those who have young children, because very often, well, home management is easier, so much easier than having to go to hospital. They don't need to leave children with anybody else. If you have motor difficulties, it's also easier. It's and everything you see things differently from home. So this is extremely important for us, for Argentinians. And then something else that I also wanted to say is that Argentina has a group of specialist doctors doing Gaucher research, and they benefit the patients. They are defining protocols. They also do the necessary follow-up to see how treatment evolves in different patients. And this is extremely important too, because that is how we are all aware of the benefits we can have from different treatments. And we know there's a follow-up from the very beginning, if there was an evolution or not, if there was what kind of disorders we have, what are the side effects. Sometimes there's no compliance, for instance, at specific ages. In teenage years, very often patients are not compliant, and here the Lysosomal Alliance, we try to support them because they need to understand that if they have access to this kind of treatment, it is important not to have to say, well, I don't feel like it, so I'm not going. No, because this is really bad for all of us. And we will be able to reap the benefits if we receive treatment duly and on time. Another important thing is lysosomal diet. ALAPA, the Argentinian Patients Organization, has been working for over 2 years so that medical schools, either private or public, in at one, well, they also learn about unfrequent diseases as one of their subject matters. They want to we want students of medicine to learn more about these unusual diseases that do exist across the world so that whenever they get their degree, once they meet someone with Gaucher or with other disease, they can have some doubts and they can refer them to where they can be better diagnosed because often people are underdiagnosed or misdiagnosed. If you don't know about something, it's impossible for you to identify that something. So we are sure that once doctors have a different kind of training about this kind of diseases, we will be able to have earlier diagnosis of patients. And this is something very relevant that we're doing here in Argentina, and I wish you could also replicate that. I am very grateful for your attention. I'm really sorry if I spoke fast. And please just let me state that the Lysosomal Network of Argentina, we are here to help. I wish that we can all together improve our possibilities for life, and let's hope that in the future we will have a kind of like a life, like Chandra says, without infusions, or at least with the same access to this kind of medication. Thank you very much.
Muchas gracias, Alejandra.
Thank you so much, Alejandra. Thank you. Thank you once again. I mean, really, thank you, thank you, thank you. I mean, well, I've really learned so much listening to you as well. And now we come to the Q&A session. Or really the discussion session for those persons participating to comment, ask, and including Dr. Simran as well, yes, about because the commitment of the association is to send the questions so that they can be also answered by him. I don't see any questions now in the chat. So, well, I'll take advantage of the fact of having the microphone, first of all, to say thank you, but also to comment on a number of things. This has been wonderful, wonderful. I mean, we've talked about, what we learn as physicians and when we go to university, but we miss what's most important. Both Alexandra and Chandra have said it, the life quality, normalcy, the fact of leading a normal life. That's what patients look for. And I believe that this is something that we as physicians should remember frequently. And something else, uncertainty. Yes, uncertainty is constant. We live it all the time. Patients, of course, but physicians also, and even a super expert such as Dr. Zimran. I mean, you saw how he talks about his personal standpoint. I think that's the essence, and we have to take advantage. I mean, the health system too often establishes a difference between physicians and patients, but in fact, we should all go together. I mean, patients trust physicians, and we as physicians know what we know, and we must always listen to the patients. So indeed, that is truly, truly what we should increasingly take into account. We are a team, patients and clinicians, and well, the health system counts with us all as a whole. And then I work on internal medicine. I love differential diagnosis. Well, let me tell you that we've lost the vision of the individual of this. And Gaucher's disease is a disease that personally, I have to say, has made me encounter once again the essence of medicine. What is it? Differential diagnosis, listening to patients, give treatments to patients, and so on and so forth. So truly, I have to say that my experience out of this meeting is just to say thank you. I'm so grateful. And as there are no questions coming, people seem to be shy, but it will make it possible that we are good about time, that for sure. But listen, I do have a question as patients. I'm asking you as patients, both of you, both Chandra and Alexandra, you have experience. So let me ask you, and it has to do with the title of this seminar. I mean, you've said so already, but in a nutshell, and from two geographical areas that are very different, but taking into account that the patient with Gaucher is the same because he or she is a person. So what do you think should be the actions, realistic actions that should be implemented to help the person with Gaucher? Because we've said a lot about distance. And I think it's ridiculous that in the 21st century, we, talk so much about geographical distance. I mean, okay, I'm a bit angry because there are some technological solutions that are not being adapted. But tell me, what can we do for patients, really, now? You have the floor. Alexandra, you want to start? Yeah, sorry, I had muted my microphone. Well, one of the things that we think of from the Lysosomal Alliance is precisely that the state should take us into account, the government should take us into account when the government is deciding, yes, who has the right or who does not have the right of receiving a medication. This is something that we believe is absolutely crucial, because never mind if somebody isn't covered by the social security, a person has to live and has to live in the best possible way. And as is the case of many patients of Gaucher's disease, I mean, we look pretty normal, so to speak. We do look pretty normal. And as they see us, with two legs and two arms and nothing missing, apparently, well, they don't think that we have a really burdensome disease that's there working inside us if we are not treated. And also, when many people have to renew the disability certificate, yes, I mean, at least in my country, yeah, people belonging to medical boards that have eyes and ears and can listen, do they think that somebody is going to invent the fact of having Gaucher's disease? They have no idea about what it is. And sometimes they are not happy about writing out these disability certificates. They should, I mean, persons who don't know what it is cannot have an opinion, and they can't say or tell us what we can and cannot have. So that is essential. And that's why we think that education is essential. People have to know about these rare diseases. One cannot, judge someone saying, no, you are not ill. What are you talking about? I'm not giving you a certificate. You don't need this. They don't know what's behind. They don't know the sufferings of people. So I guess that this is what I would highlight. And also, as Vicente, you were saying, yes, we also have to help those people who live so far away from a hospital or a center. They should have some kind of health place to go to, yeah, or if not, have internet so that they can have access to the health system. We have to make sure that these people, wherever they may be, can attend and participate meetings, find out, get information, and get what they need from the health system. And yes, the government is working on this, but more work has to be done. It's rather slow. And it came all of a sudden with the pandemic, didn't it? And that we all know. And I guess will take some time for this to happen everywhere and for people to really know how to use this. But yes, this would also solve many, insufficiencies, and it would make people get to have more knowledge and more awareness. And of course, public policies have to make sure that that is possible, because if they don't invest public money for the health of all the citizens, well, then really there will be no system that is really useful. One has to think of everyone. So I guess there's much to do still. Okay, well, yeah, we're working on it, aren't we, with meetings like this one. I also think that at the end of the day, when you go to the field of diseases like this one has to be very straightforward and simple. I mean, we talk about multidisciplinary teams. Well, yeah, but sometimes that might confuse Gaucher patients. I don't know what you think, Chandra, about this, about what it is we're talking about. So what would be the more immediate global needs, the universal needs of Gaucher disease patients? Do you see any realistic decision that goes beyond the wish list?
No sé si me...
Chandra, are you hearing me?
A ver.
Are we getting Chandra?
¿Sí?
Hello? Hi?
Yeah.
Oh, I hear you. Okay.
Okay. I was waiting you and have you heard ¿has escuchado la pregunta?
Did you listen to the question, Chandra? Could you hear the question?
La pregunta es,
Yeah, the question is,
teniendo en cuenta, más allá de las distancias
taking
geográficas,
into account and beyond geographical distances, that the person with Gaucher's is a person with more or less common problems. What do you think is the main problem that has to be solved of Gaucher's patients anywhere in the world?
So I'm just waiting for my translation.
yeah, I suppose so.
Yes, you do have. Are you hearing the interpreting service, Chandra? The question is, what should be done for universal Gaucher's patients?
I'm not sure what the most common problem would be or how to address it. Is it the problem with the trial? Or
No, el problema global de paciente Gaucher como
No, about the, Gaucher's disease patients. So what would be the most important problem to solve right now for Gaucher's patients, and how would you solve it? So what immediate problem?
yes. Yeah, so far, yes.
a realistic one, a realistic solution, please, for everybody.
For Gaucher disease, sorry, or for the trial, I'm not understanding the question, sorry. I don't speak Spanish at like very little Spanish. I'm sorry.
So you prefer to... The question is the translation working now?
Chandra,
Not really,
this is
no, it's
control. Chandra, if you have in the bottom of the app, you have a glove icon, which you can choose the language that you can hear. In your bottom right, you have a glove icon which says interpretation, languages. There is a translation online going on.
Si quieres se la hago yo.
Language interpretation.
Yes, can you hear me? This is the English interpreter. Are you getting the translation? Hello, testing? Testing. I'm testing, Chandra. Can you hear me?
Yo mientras tanto voy animando a ver si la
Well, in the
audiencia-
meantime, I'll see if anybody else has a question, and we're getting questions or remarks from the audience. Any questions?
Email if anyone has questions. Because it's not working through my Zoom call.
Doesn't work.
Not working, unfortunately.
Okay. The question is taking into account the point of view of a person with Gaucher, not a patient with Gaucher, or what is, in your opinion, the main issue to be solved now from a universal point of view? Because it's quite different depending on the countries. And I would like a proposal from you, but a realistic one, because we can talk about multidisciplinary key groups, we can talk about genetic therapy and so on. But I would like to have your point of view about a realistic and universal solution for real daily problems with persons with Gaucher. How to get your full-fledged life?
I would say definitely raising more awareness for Gaucher and making the trial and medications widely accessible for every country. I'm lucky to live in Canada where I have healthcare, but there are many countries that don't have access at all to their medication. So I think that's very important, is to have accessibility to these life-saving drugs that we do have available for our patients.
Okay, thanks so much. No veo más preguntas por aquí. No sé
I don't
si
see any further questions. I don't think. Well, I do have a comment, a remark, and well, I will ask Alexandra and then Chandra. We've been talking a lot about. Well, I really love the home enzymatic isosomal therapies. I mean, it's quality of life, flexibility. I mean, Alexandra said it herself, yeah? But now with the pandemic, it's been, well, very useful, yes? And everywhere people have defended this home therapy, but there are countries, well, typically countries where, well, this doesn't happen. It's very heterogeneous, in Spain especially. I don't know about, what do you think about home care? I mean, are people afraid? Because it's been mentioned, yeah? I mean, we've heard about even the quick ways to do it. I mean, people talk about self-administration. I would know, what's your take about home therapy and the reason why, knowing that it's heterogeneous, it still isn't really happening as much as it should. So why not? Yeah, I mean, why not?
Right. I remember as a kid, I spent most of my life in hospitals where I would have to miss schools or miss camping, a lot of life that I would miss to spend a few hours in my hospital, which became my second home. And as a young adult, I was growing to do my own infusions where I did learn to administer. I had a port and I learned to administer my Cerezyme. And the benefit of home care for me is you have your one home care nurse, hopefully, come in and you get to be at home. You can be in the comfort of your own home, and it's, sorry, I'm trying to lost for words here.
¿Es la forma habitual de
But
administración?
is it the normal way in Canada to have home therapy? Because in Spain, it's the exception. People usually go to hospital.
Yeah, it's not usually the normal way. It can be either an option or like an option if you want to, but the majority is done in a infusion clinic as well.
¿Y el paciente puede elegir el día, la hora?
Can patients name the day or the time, or is the appointment given by the hospital?
That depends on the hospital and who you're working with. I know with mine, I could sometimes choose my appointments and miss either between a day or two, but not much more than that. So I was within the 2-week period, you would get your infusion.
Okay, thanks so much. Alejandra, no sé, ¿tú qué piensas de...
Alexandra, what's your take on this home therapy? I think it's the best thing that can happen to any of us that have this disease. I mean, home therapy in Argentina, it's the other way around compared to Spain. Exceptionally, some people still go to an infusion clinic, but mostly people do it at home. There are people who feel kind of, well, they trust, hospitals more than doing it themselves at home, but it's the exception. And I mean, obviously, it's an opinion we have to respect, but every person has to be able to choose. And sometimes there might be young children and mothers, well, feel safer if they go to hospital and not really giving them, the infusion. But yes, I think that once somebody tries to do it at home and does it well, you don't want to go back to the hospital ever again. It's much better to be at home. I have the experience, thank goodness, that 22 years ago, I mean, I was given only 2 infusions in a clinic, the rest always at home. I really learned at a young age, and it's just fantastic. And one can, you can decide what time you're going to do it. And going to a hospital is shocking. It really, you can't go to work properly. Every 2 weeks, you miss out on something. So home therapy is fantastic, incredible. Really, it's really very good. Okay, great. Well, now, yes, we're running out of time, and there are no questions coming in from the audience. I don't know whether you two, Chandra and Alexandra, would like to say something as a take-home message before we go on to the closing of the meeting. A very, very, very interesting and enriching meeting. let me tell you, home therapy, I'm a fan of home therapy. As you said, Alexandra, I mean, if there is something we've gained in Gaucher's disease, it's the possibility of this tailor-made treatment. We even have, well, we have so many different, home therapies, and not everybody has to go to hospital, or not everybody has to go for home therapy, but the fact of being able to choose is very important. It's, individualized medicine for a disease that we had nothing for 20 years ago, and all that's to come. So any take-home message, does any remark you have? If not, we'll go on to the closing session of this seminar. So please, do say. I have a sentence, Vicente, if you allow me. I found it, I read it, and I decided I would keep it for everyone. I think, well, for all those people with a disease that's a lifelong disease, yeah, whatever disease it may be. Yes, one can break, one can give up, one can cry. The only thing you cannot do is do nothing. You have to understand things will happen in your life, and things will not always go the way you want them to. That's okay. What's bad is to say, I can't continue. Dare go forward. Learn from what you lived. Go, stand up, stronger than before. Everything depends only on you. Thank you. Very good. Thank you. Chandra, any take-home message from you? Do you want to close this? You're the stars.
It was said beautifully. I couldn't have said it better, and I agree with every point, and that was beautifully, beautifully put. I love that. I couldn't even add to that. Thank you.
Muchísimas gracias a todos.
Well, thank you very much indeed. Thank you. And now we shall go on to the closing of this meeting. And, well, as somebody who is the visible face, well, we have Jordi Cruz. You all know him. He's the director of the MPS Association, Lysosomal Diseases, and he will be closing this very, very interesting seminar. And I really have to say, I mean, I apologize, but I have to say that I really liked this meeting, so enriching. Thank you, and the floor goes now to Jordi Cruz for him to close this officially. Thank you. Thank you. Thank you so much. Thank you. It's been such a pleasure to have you here chairing this session, Vicente, and having such an interesting session. My thanks as well to the speakers. We have had truly extraordinary speakers. We had Dr. Zimbrand, first of all, who gave us such an interesting conference. Then Chandra, with her experience of gene therapy, something that so many of us are looking towards, yeah, to see whether we can solve the disease once and for all. And also Alexandra, her experience is crucial, yes. I mean, such a journey, and then the work with the foundation and, association work is so truly important. I also wanted to say thank you to the technical team and to all the people connected. So good. We'll have this recorded so that we can have it and listen to it later on, and, well, make it available to people who couldn't be here with us today. And yes, truly, we learned so much, and we learn, I mean, moving as an association of lysosomal diseases, yes, this is who we represent. Well, it's good that we help as much as we can. Our association has been working now for more than 20 years for lysosomal diseases, and truly, yes, there are many needs that we are gradually meeting. One is to take care of the patients and their families. That's what's most important. Of course, we have physiotherapy, psychotherapy, we have sexology, assessment, and counseling. And we also have a medical committee where one can deal with any specific situation or subject. And we have just an incredible team to be able to organize these events like the one this afternoon. And you can follow us on our website as well. You have all the information. What we also do is try to be next to the families and the patients. We want to be there with them. We think it's important to know what their needs are and to meet their needs, not only in everyday life and quality of life, but also understanding what clinical trials there are, where they are, and where they might comply criteria so that they could become a part of the clinical trial. And this we do at Spain together as well with the international network. We do what the maximum we can to be there. And what's been talked about this afternoon is what is so important. Home therapy, essential here in Spain. We have a way to go. There is, well, inequality in access to home therapy, even access to treatment, and we don't understand this inequality. So we have to make sure to work together so that everyone has the same opportunities as patients, and so that we can all work together to go for better results. And that's what's truly important. So, well, the idea then is to make life better and easier for Gaucher's patients and their families. That's what's essential. So once again, thank you all for being here with us. Thank you truly to the speakers once again. It's been great. We'll keep the contact and hope to see you soon. So have a very good day. Goodbye.